Welcome to Doc Talk, a weekly podcast featuring Monument Health physicians addressing medical topics. Tune into your health with Monument Health. Hello again, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and joining me again for this episode, Dr. Nicholas Czosnyka and Dr. Moyer from Spearfish. Doctor, nice to have you back.
Good to see you, Mark.
It is nice to have you in the conversation here, and this is fascinating to me right now. In a previous podcast, I was talking with Dr. Nick about varicose veins and general surgery and some other things that he does, and he mentioned when you were coming in that you guys work as kind of like a tag team on the subject we're about to talk about today, which I think is quite fascinating. And it's on breast cancer and breast reconstruction.
Correct.
And Dr. Nick, I suppose you would be the first step in this, wouldn't you?
That's right.
So how does it begin?
Right. And so when we talk about breast surgery, we're kind of at this fork in the road. Are you going to have breast conserving surgery where we're doing only the minimal amount of breast removal to remove the cancer but still leaving your natural breast tissue? Or are you going to have some form of mastectomy or removal of all the breast tissue? And so plastic, Dr. Moyer will speak to all this, but plastic surgery can have a role in both cases, but most commonly when the breast is removed, if the patient wants to maintain cosmetic normalcy and have breast tissue, the appearance of breast tissue, well, then they need to have reconstruction, right? And so the application of mastectomy is a long discussion, a long topic, but I'll kind of summarize it by saying, okay, well, someone could have a large cancer that is not amenable to having only a portion of the breast removed. They could have a desire, right? After all the decision-making kind of pathways have been discussed, they could have a desire for a mastectomy. Or they could have high risk where, let's say they don't even have breast cancer, but their lifetime risk of cancer is such that we are prophylactically recommending the removal of their breasts. So in any of those cases, if the breast is removed, reconstruction would be necessary.
And there's really, there's kind of generally two types, correct? There's the mastectomy and then there's a lumpectomy, correct?
Right. So that's that breast conserving.
Okay.
So a lumpectomy, think of it in real simple terms. Okay, if a cancer is detected on imaging, it may only be a centimeter, right? Maybe the size of your fingernail. It's small. And so the majority of people have a breast that amount of tissue could easily be removed and you'd never know it was removed, right? So if we could remove that little kind of marble of tissue plus the addition of what we would call a margin or a little rim of normal tissue, and we can prove that under a microscope and say, hey, we got the cancer out and every other surface around that cancer is free of cancer, then we can say it was completely removed, right? So, and that can be done through an incision that maybe is only, an inch.
Okay.
And it's much less invasive. It's a same-day surgery. But again, that can only be applied in certain cases. We try to apply that in as many cases as we can. And even if there are large lumpectomies, there still may be a role, but the reconstruction techniques are different.
Okay. Now, after it's been determined with what they want to do and the procedure has happened, whether full removal or lumpectomy, and now they want to get into the reconstruction side of it all, can these procedures be performed in the same day? Do you guys work together like that?
So, absolutely. Obviously, and Nick said it like we talked about it, there's two different divergent pathways. Mastectomy patients will have their mastectomy that day, and most patients will have immediate breast reconstruction at that time while they're still asleep. And that may be a two-stage process, but the first stage will start right then. Breast conservation therapy, the patients that Nick was talking about, the lumpectomy, only removing part of the breast, some will come to me for reconstruction, but that will generally be down the road. That will generally be a year and a half later. Once that breast is settled after the surgery, after something called radiation, we'll also apply radiation to that side. So they see me on a much later basis. Now, the mastectomy patients, that's a concomitant surgery Nick and I perform together. Nick starts. Once he's done, then I enter the room and immediately start reconstruction.
So there doesn't need to be I suppose, I mean, the incisions are made and things like that are already done, so you can step right in. There doesn't need to be any sort of healing at all.
No,
really.
actually, we kind of want to get started right away. Number one, it's been shown to improve the psychological aspect of the entire process, and it saves another additional surgery with anesthesia. And so we do prefer immediate breast reconstruction. There will be a few times when we'll delay it by a week just to make sure that the pathology looks good, but mainstay will be immediate breast reconstruction at that time.
Is anybody that wants it, can anybody be a candidate, or are there instances where even if there's cancers where you're like, well, we can remove it, we can fix it, but I don't know if reconstruction is something we can do? Or
reconstruction options, one, it's patient choice.
Sure.
Not all patients want reconstruction. Number two, there are certain stages where, very, very advanced cancers, and this is rare, but very advanced cancers where you can't. So when Nick does a mastectomy, he leaves behind, when you think about your breast, it's skin first,
right,
nipple, and then fat in the actual breast parenchyma or tissue. And so in most instances, Nick is going to leave behind skin and or the nipple complex, and so I just have to make a breast mound. There are certain cancers, very aggressive cancers, where Nick, and he can speak to this, is going to have to remove some chest wall or some skin or a lot of skin. And so then we're really on just trying to fix that patient, not trying to make a true breast reconstruction, but just trying to get them healed. And Nick, you can speak to that.
Yeah, and so when we talk about a cancer, right, we need to understand the extent of its invasion, right? Whether that is locally in just the breast alone, has it invaded into the skin overlying the breast tissue? Is it invading into the chest wall? And so reconstruction can only be applied if we can leave behind tissue to reconstruct.
Right.
And so if there, again, just that basic concept, if the if the cancer is involving a large amount of the skin, the chest wall, or let's say somebody has had what we call an inflammatory breast cancer, or a cancer that's really kind of diffusely spread through the breast and the skin, it may not be an appropriate choice to leave behind the tissues that are necessary for reconstruction that may or may not be free of cancer.
So if somebody has kind of the more serious side of it, like you've said, or let's say they have mastectomies and they don't want it done right away. They're thinking maybe, I'll try it without.
Sure.
Can they come back a year down the road, 2 years down the road?
After mastectomies, you can absolutely go through delayed breast reconstruction.
Okay.
Now, there's three main pathways. So this is getting pathway dependent, but we've got two main pathways for breast cancer that we talked about surgically: breast conservation therapy and mastectomy. When we talk about now mastectomy, there are also three main reconstructive options. The first is to use an implant, these silicone gel devices, manufactured implants, to reconstruct that breast mound. The second is to use your own tissue, and that generally comes from your abdomen. So quite a few of us in America have extra skin and fat, right, in our abdomen. And we can use that that tissue and mold it into a breast mound. Clearly, it has to bring its own blood supply in it. And so these are very complex surgeries, making sure that the blood supply comes with the tissue. And then there's a combination of both where we use the muscle of your back, called the latissimus muscle. That's the one that kind of sticks out here, right?
Yep.
And we'll harvest that muscle, again, based on an artery and vein, and tunnel it underneath the skin in the axilla and drape it in to make a breast. Now, generally, that's not quite enough to make a breast, so we'll add a small implant. But those are the three pathways. If you choose delayed reconstruction, I am always going to have to put a tissue expander in. A tissue expander is going to re-expand that skin, because if we don't do anything right away, that skin will retract and scar down to the chest wall. So people can come and have delayed breast reconstruction, but we just know that it will always start with that expansion phase, and then all those three options are available. So that's the only caveat to delayed breast reconstruction.
So what's recovery time on something like this after it happens?
Yeah, so I tell people in general terms, right, this is a weeks, not days recovery, right, because it does play out. There's the immediate day or two after surgery where you're in the hospital, you're leaving the hospital, you're just getting home, you're sore. Maybe the soreness lasts for week, two, but it's getting better as that time goes on. But there's drains involved, drains that are pulling fluid out from the area that's reconstructed. Those may be in for 2-3 weeks sometimes. So I think to put it in terms people can understand is, okay, there's these couple days that I'm feeling acutely like I just had surgery. And there's a couple weeks where I'm really starting to feel better, but I still wake up and feel like I had surgery recently. And maybe it's 6 weeks, 8 weeks before you wake up and you say, hey, I really feel like I didn't just have surgery, right? So it is every day is a little better, but it plays out over weeks, not days.
So what do you recommend, or what do you tell your patients after it's all healed and it's all good to go? Do you tell them, look, you're just like you used to be? Or is there anything they have to be careful of or watch for?
I'm going to let Dr. Moyer speak to that.
Down the road. I mean, because that's a big surgery, no matter how you look at it.
And just like we've broken it down, mastectomy patients have different. We're going to talk about two different things: surveillance, cancer surveillance, and then my aspect of reconstruction. So lumpectomy or breast conservation therapy patients have a little bit different surveillance, monitoring whether a tumor recurs again, versus mastectomy. Not saying that mastectomy has a zero chance. But then the other option, is asking, am I done? Am I normal? Well, so, the idea here is that we talked about that breast, and that breast, natural breast, has sensation, right? Mm-hmm. And it has different, different functions. After I reconstruct a breast mound, to be honest, it's not a God-given breast. It
right.
does not have sensation. There are, with implants, we monitor them on a yearly basis just because there are potential complications of implants. We call them 20 to 25-year devices now, but there are certain issues with that. With using their own belly tissue or their back tissue, we follow them up quite a bit, especially to make sure that they have appropriate muscle function and or core strength, back strength, and scar tissue and the like. So generally, I'm following these patients for quite a while. And once we get to about a year, then it's a yearly appointment with me, just to make sure that everything's appropriate.
Yeah. So you had mentioned, I'm sorry, did you want to add something to that?
I was going to kind of piggyback off that and say, okay, with regard to surveillance, right? Somebody's had a cancer, they've had it treated, right? Like Dr. Moyer pointed out, in that pathway of lumpectomy, there's still a lot of breast tissue. So that patient is really going to essentially follow a normal screening pattern, right? They still need mammograms. Now you take somebody who's had a mastectomy, whether that's for cancer or whether that's for prophylaxis, they don't have breast tissue, right? And so there's kind of a debate here as to what's the best way to screen that patient. And most people rest on physical exam, right? Mm-hmm. We're gonna take this as it comes, right? If you feel something change, we'll investigate. But let's put it in the context of that prophylactic mastectomy. The whole reason we are doing that is so someone doesn't have to go through yearly mammograms and MRI because of their high risk. So to say, we're going to put you through this surgery and reconstruction, and then you're still going to do an MRI every year, that's not a good endpoint, right? Right. So in most cases, it becomes a physical exam first, and then based on any changes, investigation.
Yeah. And kind of speaking of that a little bit too, how often realistically should women have mammograms? Should they be checked?
Yeah.
Is there kind of a consensus on that?
There are many different consensus statements. Whether you're looking at U.S. Preventative Task Force, you're looking at American College of Obstetricians and Gynecologists, family medicine, internal medicine. There's all these different ones. The one that I would say is start at 40, do it every year. That's the simple kind of take-home message. You can find variations on that recommendation, but yes, you should be getting a mammogram at 40 and then every year to follow.
Excellent. Again, this has been a fascinating conversation for me, for sure. I love talking to both of you guys. It's been great. Dr. Nicholas Czosnyka, Dr. Moyer, both from Spearfish Monument Health.
Moyer's here in Rapid.
Oh, you are here. I'm sorry. That's right. You are here in Rapid City.
But I'm in here in Rapid. Nick's in Spearfish. I operate in Spearfish with him at times. He comes down and operates in Rapid at times. So you can call us both.
You guys share. Yeah, excellent.
Yeah,
that's perfect.
No, absolutely.
So Black Hills.
There we go. We'll stick with that. That's perfect. Thank you, gentlemen, both for talking with me again. I really appreciate it.
Yeah, thanks, Mark.
Thank you.